Good afternoon, everyone. I'm Susan Hoffman, the director of the Osher Lifelong Learning Institute, and we're really glad that you could join us this afternoon. We have Dr. Deborah Gold, who will be here to talk with us about COVID-19. And I want to say just a few words about Dr. Deborah Gold, who we call Debbie, who has been offering these kinds of sessions throughout the Bay Area and has been an OLLI faculty person with us, teaching several times a course called Infectious Diseases in the news. Her background is that she has been a medical doctor for almost 40 years. Her medical degree is from UCSF, and starting in about 1981, 82, or 84, 85, 84, began to really specialize in infectious diseases. So we have an extraordinary expert with us who has not only a long and illustrious medical degree past and practice, but also has been very concerned around how to communicate these issues in a public health manner. We have asked you if you would like to ask questions, and many of you have responded when you registered with a set of questions. We will start with Dr. Gold addressing some of those questions, but her intention is if we don't handle all questions, that we will do a follow-up to you following today's event. Today's event is also going to be made into a podcast on Berkeley Talks and no doubt available in some other forms as well. But thank you all for joining us, and Debbie Gold, thank you for joining us. And it's all now up to you.
Okay, thank you. Hello, everyone. And I just wanted to say that we'll answer all the questions that were submitted beforehand in writing if we don't get to all of them, which I guarantee we won't get to all of them because there were so many. And I also just wanted to say that about my being an infectious disease physician, I didn't have my first real job until I was 32 years old. That's how long it takes from kindergarten to practicing infectious diseases. So, and going straight through. So I thought that I would take some of the questions off of the ones that were submitted beforehand, and then we'll go to the to questions that are submitted in the chat. And I think I would like to start with a question that seems really so simple, but the answer is not simple at all. And that is, how long does it take for a person to become contagious once he or she has contracted the virus? It's often not known exactly when exposures take place. However, we don't really know the answer to this question, but I will try to provide some context for a possible answer. There was a study done that combined 7 different studies where the actual date of exposure was known, and they looked at test results on those individuals, and they found that if they tested on the day of exposure, or the next day, or the next day, or the next, so within 3 days of exposure, they could not pick up virus on the nasal swab testing, the PCR testing. And so that means that there's probably so little virus there in the first, say, 2 to 3 days that it's very unlikely that one would be infectious during that time. But I don't want to say never because we don't really know the answer to this question. And I'm kind of using some data to suggest an answer that might be off by a day or so. But certainly within, if you are going to develop symptoms, certainly you're infectious 2 to 3 days and maybe even as long as 6 days before the development of symptoms. So hopefully that answers the question. People are definitely infectious during the pre-symptomatic period, and even if they never develop any symptoms, they are infectious for some period of time, a week or perhaps longer after the point of exposure. Someone asked about teachers returning to the classroom, and I assume that's teachers over the age of 60 or individuals who have medical problems that would put them at increased risk for severe disease or death from COVID. I think that returning to the classroom in person would be risky for somebody who is in one of those categories. I think high school would be the riskiest because kids in high school teenagers would tend to blow off social distancing and wearing masks. I think that K through 3 is a special situation in schools because of some data from Iceland, where they had tested huge swaths of the population, which is only about 360,000 for the entire country. But in testing these huge swaths of people, they tested almost 900 kids who were ages 0 to 10, and none of them had infection. And so we think a little bit differently about kids in that age range 0 to 10, that they rarely get infected. And so if you are a teacher of, say, K to 3, you might be a little bit more protected just because your kids are younger. But I think that doing remote teaching is the safest if you are over 60 or in a risk category. How about safety for people getting haircuts, massages, and riding BART? I think I would put into that, to this group, getting your nails done and getting a haircut with color. Even though I don't know too much about either of those, I think they're, they take up time. So I think the risk here is that you are less than 6 feet from the person who is performing the service for you. By definition, they have to be close to you. They're probably also talking to you the whole time. And even though they're wearing a mask and you're wearing a mask, there are some virus-laden particles, droplets or aerosols that are going to penetrate that mask and float in the air between you and the person who is doing your hair, giving you a haircut, a massage, etc. And so I think that you have to consider what your risk tolerance is to do something like that. I think you also have to think about the kind of mask that you are wearing, the kind of mask that your haircut person or nail person or massage person is wearing. Does it fit very well? How is it wet already because it's late in the day? So is the integrity of that mask really not very good? Does that person have any symptoms? Because people are now incentivized to go back to work who have not been working and might work when they're ill and might not disclose that to you. So that could be a risk. Or does that person live with somebody who is in a risk category, like somebody, or in a category of a person who might be infected? Like, do they live with somebody who works in a nursing home, or somebody who works in a congregate work setting like a meatpacking plant, or some kind of manufacturing where people are very close together, where we know that, or work in a prison? Oh, let's not forget prisons. So where infection runs rampant, and could that person then be asymptomatically infected by the person in their household who works in a congregate setting? So I think that those are all things to consider when you're thinking about getting a haircut. I'm not getting a haircut anytime soon. Oh, here's something else. It takes, a while to get your hair cut and also to get color or whatever, a manicure, a pedicure. And you may be in a place that doesn't have very good ventilation, that doesn't have windows that are open. And we know that aerosols that are expelled by people who are asymptomatically infected, who are talking or breathing, those aerosols can stay in the air for long periods of time, even hours. So if there are not very many air exchanges in the place where you are, and the window, or there aren't any windows that can be opened, that poses a greater risk to you for getting a massage or a manicure or a haircut. I think BART is public transportation is something where you probably are not going to be able to do social distancing, where people who are ill may be riding BART even though they're wearing a mask, where you're having to touch surfaces to hold on to a strap or to a pole. So I think if you have to use BART, you should understand that that does pose some risk to you and that may be unavoidable, but you should keep alcohol-based hand sanitizer on you and use it as soon as you get off BART. You'll have a mask on so you won't touch your face, don't rub your eyes, and just get as far away from people as you can if you can. Testing. People asked about what is the difference between nasal swab testing and serum testing. So the nasal swabs, which can now be done on saliva as well, are tests that directly detect the RNA or the nucleic acid of the virus and tell you you are infected right now or you're not infected right now. And they're good for that moment. So, and there has to be enough virus to be picked up, as I alluded to in the first question that I answered. So that is a test that is being done in all the testing centers, basically to allow people to know if they are infected right now and therefore infectious to other people. This is not a perfect test. It has a sensitivity of about 80%. And that means that 20% of individuals who are infected will, the test will not pick up the infection, often because the test is being done too early. They were just exposed a few days ago, and so there's not enough virus around to be picked up, or it's too late and they've already passed the period when they have a lot of virus, which is in the first week of illness or the first week after infection. And so now it's too late and the virus is no longer present. So doing a swab will not tell you that you're infected right now, even though you are, and you just have a little bit of virus that can't be picked up by the test. The serum testing is actually antibody testing. And that is a test that tells you that you have been exposed sometime in the past. Like all of us have, if we do a blood test for measles, we will all have measles antibody if we're born before 1957. And you will keep that marker, you will keep that antibody in you always. So in the same way, if you have antibody to this particular coronavirus, it will be picked up by that test. And will tell you that you have been exposed. Now, unfortunately, it's not as straightforward as I have just said, because the sensitivity of a lot of antibody tests are maybe not great, so they're going to miss some people. On the other end, the specificity or the identification of individuals who truly don't have the test is not great. And so some people who have maybe had other coronavirus infections that have just caused colds, there might be cross-reactivity, so people will be positive in a test, but it's not because they had the test, it's because they have cross-reactivity with another virus, or they live in an area where not very many people have had this infection and the test is known to have a false positive rate. So say that the only 1% to 2% of people in the community are known to have had infection, and that's like true in San Francisco. That's probably what the prevalence is. And if you have a test that has a specificity of 95%, it means that 5% are going to be false positives. If you are positive in that test and you never had any symptoms, you're just doing it for interest, there's a 5% chance that that's a false positive test, which is greater than the chances that it's a true positive, which would be only 1% to 2%. So boy, I hope I'm being clear about that. It's super complicated, but antibodies can overcall and undercall infection. Let's just put it that way. And we're learning a lot more about this, and the FDA is sort of going through all the tests that are on the market now, many of which are highly unreliable, and trying to get them off the market so that we're left with tests that are more meaningful. Somebody asked about sanitizing iPhones and iPads. I don't sanitize my iPhone or my iPad. They kind of stay in especially my iPad, I never take it out of the house. So I think that I'm not probably transmitting, I'm not transmitting viral particles on my hands to my iPad. My iPhone, I do take out of the house, but I go out of the house so rarely, and I do clean my hands when I come back into the house. I don't think it's a really high risk thing. As long as you're keeping your hands clean on a pretty constant basis, it's unlikely that your phone will be contaminated. But if you think that it is, you could at least wipe the back of it and the edges of it with like some kind of a alcohol wipe or something that would sanitize it without damaging it. So any questions coming to me through the chat, Susan?
No, there haven't been any questions yet. Let me just...
Okay, because I can keep going. I got a long list here.
Oh, that's great. Well, we can, anybody who is just joining us, please know that you can ask a question now, either in the chat room or by raising your hand. Max will call on you. If your hand is raised, it is, if you can raise the blue hand that's in the directions, I guess it's under participants. But Debbie, that was great. One of the things I want to mention is there is a new product out that has a UV light to clean your iPhones. So you put...
Somebody down the street from me got one of those, and she got it like when it first came out. She said, right. Got this thing on Amazon and it cleans my iPhone, and I figure it can't hurt. I said, Harriet, I think you're right. It can't hurt.
That's what they say.
And, I'd say, go for it. It's probably okay just to use a wipe as long as you're not wiping the screen.
Yep.
Just to,
Yeah. Well, here, and then the other question around infectiousness, which I know it is also further down. Many of us are walkers in whatever city or place we live, and all of us are wearing masks. But it seems that the joggers, who are both passing us and coming towards us, how do we negotiate the street, the sidewalk, the joggers with or without a mask? That is a minefield right now.
I have the same problem. And you should hear me when they, oh boy, they come up behind me and I don't hear them until they're right up behind me, and they're inevitably, they are not wearing a mask. And I have to console myself by saying, at least we're outside. But I think that a jogger who is potentially asymptomatically infected and who is panting, that person is expelling more droplets, more aerosol, and it stays in the air and can actually be propelled forward many feet. And the aerosol even more farther farther forward. But fortunately, being outside, the air sort of dilutes that effect. And so as long as they're not like with it, I just try and maintain as great a distance as I can. If I see a runner coming for me, I will either cross the street, or I'll cross the street and I'll go up on a driveway and just stay as far away from them as I can, because I don't want to walk into their droplet aerosol
right.
That's coming out of their mouth.
How long does it stay in the
being
air?
Outside makes it less dangerous.
Got it. Okay, well, we've got a couple of questions that are coming in. Christina Jansen asked, do you recommend a face shield and a mask for someone who has immune suppression?
You know, I think that the main role for a face shield is for a healthcare worker. In order to prolong the lifetime of their surgical mask or their N95 respirator, which are in short supply, sort of in an ongoing basis. So if you are a healthcare worker and you're having to wear one surgical mask or one N95 respirator for a prolonged period of time, perhaps a whole 8-hour shift, then you can use a face shield to prevent droplets from a patient coughing on you from contaminating your mask. I think that that is the main use for that. It wouldn't occur to me for an immunocompromised person to wear that. I would say if I were an immunocompromised person, I would be staying in as much as possible, and I would be wearing as good a mask as I could get that fit my face as tightly as possible going out, and I would try and really minimize the going out part.
Thank you. Beverly Fetter is asking that she has contact with her 3-year-old granddaughter, and her granddaughter is seeing a nurse who works with COVID patients.
Oh.
What should she do?
Oh, well, you know, some situations are just, does she have to have contact with the nurse who deals with the COVID patients? Because I think that's, you know, a little risky. It's nice to know that kids 0 to 10 have a decreased risk for acquiring infection, and there's some physiologic reasons that are now coming to light about that. So I guess her risk, as long as this is a 3-year-old, maybe she could feel better about that. I would feel even better about that if the 3-year-old didn't have contact with a nurse who takes care of COVID patients, but hopefully that nurse is taking meticulous care at work not to become infected his or herself, and, you know, will not bring the infection home. Or bring the infection to other people outside the hospital.
Okay, we have a caller on the line.
Okay.
Linda. Linda, I'm allowing you to unmute yourself.
Aha, okay. I see people in cars wearing masks. Are we supposed to do that? Why are they?
No. In fact, I see people in cars too, and I'm like, hello, why would you're sitting in your car, why would you be wearing a mask? Maybe, and it's usually like one person in the car.
Yeah.
I can't understand why a person would wear a mask in the car unless maybe you were an Uber driver or a Lyft driver, and maybe you were picking up a passenger and they were expecting you to wear a mask, or that's the only reason I can think of. But if you're just in your car, driving your car, there's no reason to wear a mask.
We have another infectious question from Peggy Cassidy. What is the risk of traveling to a family reunion in Ohio where I have to pass through 3 airports to get there? My relatives say no one is wearing masks back in Ohio.
Yeah. So there's the red state, blue state business there. Yeah, my sister, yeah. So I think that going on an airplane, and a lot of people asked about air travel. I don't think it's so safe to do air travel. It's even if every other seat is not taken, so in other words, the middle seats are blocked, I don't think it's possible to maintain 6 feet of social distancing in an airplane. And you don't have any assurance that everybody is going to be masked, or if they are masked, what the quality of that mask is or what the fit of that mask is. And people are going to have to take off their masks to eat and drink. And the air is recirculated, especially in coach. Now, I think it's not quite as bad as it used to be, but you used to be like the air, the number of fresh air exchanges in coach is certainly not what it is in first class, not what it is in the pilot's cabin. So you have a risk of breathing in aerosol from somebody, rows behind you or in front of you, or or the row next to you. So I think it's not terribly safe. A long plane flight would be riskier than a short plane flight. And then going to a destination where individuals are not complying with social distancing or masking is hazardous also. And if I'm over 60, I wouldn't do something like that. I would do a remote, I would sort of remote into a reunion and not go there in person. I think it's too risky. And you have to know what the cases are like at the time. So, there are websites where you can track cases by, I'll tell you the website. It's 1.3 acres, 1.3acres.com. And that you can track any state, and then it'll tell you by city how many cases were diagnosed yesterday, how many deaths were new deaths yesterday, and you can track that by the day and find out that for that particular city, what is going on there as far as transmission. And that would make it even scarier if cases were going up. And if nobody's masking or social distancing, cases are going to be going up.
Mm-hmm. Okay, next question. What are the increased risks if one has controlled high blood pressure and a history of a fib?
So atrial fibrillation is not per se a risk factor. Hypertension is a risk factor, and I believe it's a risk factor whether or not it's controlled. And so even if your blood pressure is under good control, you should still consider yourself at increased risk for severe disease. I have seen numbers from China as high as 15% risk for severe disease. And so I've also seen numbers as low as 10 or 11%. So it's somewhere in there, and it doesn't matter if the blood pressure is controlled or not.
Aha, okay.
Okay, we have someone who wishes to get on the air. Lucy Smalls-Reed. I've allowed you to unmute yourself. Here she is.
Yes, thank you. I'm sorry, I just wrote out my question. I joined you late, and I wondered if you have talked yet about what particular issues make older adults more susceptible to COVID-19 and to have worse outcomes. Are healthy older adults without chronic health conditions still at higher risk?
Yes. So that's what I would consider myself, a healthy older adult, and I do consider myself at risk by virtue of my age and nothing else. Unfortunately, your immune system degrades over time. And so it's something that you can't really do anything about. It's just a thing that happens. And as you get older, your immune system is just not as robust as it used to be. And that's why, like my entire career, taking care of patients with infectious diseases, they're always worse in individuals who are older. So that, and I can't say exactly which parts of the immune system, but it generally, it's a thing that people who are older just don't have as robust an immune system. And that is why this infection is taking such a terrible toll. But also people who are older often do have other medical conditions that will put them at increased risk, like diabetes, hypertension, cancer, chronic obstructive pulmonary disease, and importantly, super importantly, obesity, very important risk factor for severe disease and death from COVID-19.
Thank you.
Debbie, we've got a variety of questions about masks. And so the range of questions goes wanting to learn a little bit more about what are the best masks, the N95 masks. Can you clean your masks effectively? And let me see, there was a couple of other things. Well, to start with the whole question around mask wearing.
Okay, so the most effective mask is the Fit-Tested N95 Respirator. And what I mean by fit-tested is when you're a healthcare worker, so this is something I used to have to do every year. I would have to put on an N95 respirator and have a special hood over my head, and this takes half an hour. The fit tester will spray this very bitter tasting thing into a hole in this hood, and then if you can taste that, it means that your mask is not fitting properly. So it's an assurance that your mask fits properly, and that will filter out 95% of aerosols. And it will protect you from getting tuberculosis, which is basically the reason that I would wear an N95 mask, mostly to have contact with TB patients. So that is the best kind of situation and the thing that will protect you the most. And really that is restricted to healthcare workers who can access fit testing. So, but people also have N95 masks that they bought at hardware stores. We had them in the house when the fires were bad and we needed to, wear them. And if they fit tightly on your face and they have a nose crimp, that probably provides the second best protection. Although there is no guarantee of filtering 95% of aerosols wearing a non-fit tested N95 mask. By the way, there are N95 masks that contain a one-way valve so that every time you exhale, your exhalation goes through that valve. That kind of mask is not protecting anyone around you because whatever you are exhaling is going through that valve. And in fact, if you go into Trader Joe's wearing one of those, they'll make you put a piece of tape over the valve. So you should just go ahead and tape it yourself because you are not protecting anybody wearing a valved mask. The third best protection is a surgical mask. A surgical mask is one that is an FDA-approved surgical device, and it's not the thing that you buy on Amazon when you type in surgical mask. Those are paper masks that are not FDA-approved for use by surgeons and will not filter out droplets or aerosols to the extent that a real surgical mask will. If I could get my hands on a surgical mask, I would totally do that, but I don't work anymore and I can't go by the operating room and get me some surgical masks. So now we're left with cloth masks. And cloth masks can be effective in containing droplets coming out of your mouth and aerosols coming out of your mouth, so protecting other people, but it certainly doesn't contain all of them. And it can, depending on the fit of the mask and the type of material that's used to make the mask, it can actually offer you some protection as well. I'm giving a talk tomorrow. I give a talk every Wednesday morning on COVID, and tomorrow I'm talking a lot about masks, so this is very fresh in my mind. The data for masking comes from the mid-2000s when there was a lot of concern about the prospect of an avian influenza pandemic like H5N1, H7N9, the avian influenzas that have been popping up periodically in China. And the mortality from those avian influenzas is in the range of 35 to 70%. So basically your chances of surviving one of those, if you're, is pretty low and you want to be able to have good protection. So the question was, could you make a homemade mask that would provide you some protection in the setting of an avian influenza pandemic, where the death rate, you think this is bad, this is nothing compared to what we would see with avian flu. So they tested t-shirt material, tea towels, vacuum cleaner bags, linen, cotton blends, pillowcases, antimicrobial pillowcases, all, as many things as you can think of. They tested them, and basically they came to the conclusion that none of them was going to provide meaningful infection against an avian influenza in a pandemic setting. I look at those data and say, I think they're better than nothing. I think they're probably better than wearing a bandana. And so I have looked at these data and some more recent data looking at 1 layer of silk, 4 layers of silk, combinations of cotton and flannel, cotton and silk. I wish I could share my screen and show you these data, but 4 layers of silk, it's pretty good. That's what I'm using, 4 layers of silk. And I'm tying it pretty tightly around my face. So if I'm like going in the grocery store, which I still do once a week, that's what I'm using to protect myself. If I had a sewing machine, I would use a high thread count cotton on one side and silk on the other side, and I would create a mask, a very good fitting mask with a crimp over the nose, and I think that would provide pretty good protection. Not great, not like an N95, but better than a regular a cotton mask that you just, maybe doesn't fit very well. Or I think it would provide a little bit more protection. It's still not great, but it's better than nothing.
And Debbie, in your experience, the N95 mask is hard to exercise in.
I would say it would be impossible. Having worn them for hours and hours, just, when I was working, it's really hard to sit in a room and take a history from somebody and do a physical in like an hour. It is almost unbearable wearing a Fit-Tested N95. It's just so hard to breathe. That's why it works so well. It's hard to breathe.
Right. And I know a lot of us have a feature on our dryer that allows for steam cleaning. It's either to refresh or do a sanitary clean. Yeah, so I wonder if that might be used by some that have the cloth masks.
Well, the cloth mask can be washed, and I would say, after you've worn them a couple times, I'd probably just go ahead and wash them. If you're wearing one for hours on end, I probably would just wash that even after just one use. And if you are, I think there's some benefit to maybe putting them out into the sun, because UV light and heat does, inactivate the virus. So if it's a sunny day, you could put your mask outside and maybe get some benefit that way. Or put it into a dryer with some heat would kill the virus too.
It would. Okay. And since we're talking about these kinds of filters, there's been a couple of questions about air filters. And so someone said their dentist said they had a HEPA air filter. I know when I asked the university about what filters they were using in a building where the OLLI office will be, they said that they were using, it was an ultraviolet light air filter that they were using in the ventilation system. Have you heard of these kinds of things making a difference?
Well, so I know that in the hospital we would use HEPA filters to create a negative pressure in rooms where that was necessary, like for TB patients, when all of our negative pressure rooms were full, we could create a negative pressure room using a HEPA filter. The filter has to be the right size for the size of the room, and it should vent to the outside. So I think where the HEPA filter vents is important. UV is also something that we have used in the hospital to sterilize or to terminally clean rooms. When UV is used to do that, to kill bacteria and viruses on surfaces, nobody can be in the room when the UV unit is on. And I think for some period of time after it's off, no one can enter the room. So I'm familiar with HEPA and UV in the context of a hospital setting, but not in a building or, you know, a office setting. So I don't really know very much about that.
Okay.
I don't know anything about that.
Yeah.
I should say.
Okay, we've got a question from Ellen. Ellen, you're on the air.
Okay. My question is that I read recently that the recent outbreak in Beijing is a more virulent strand of this virus. So my question is, with the various ongoing clinical trials that are now underway with potential vaccines, is there a way that they can introduce this new strain into the testing, or do they have to start from scratch going into?
So I have been reading a lot about that outbreak in Beijing, which is very worrisome. Although I think they're jumping on it now because they learned their lesson the first time around. I have not read any evidence, at least in the literature that I am following, that it is a more virulent strain. I have not read that at all. While the virus has been mutating in a way that we would expect, there has not been a significant increase or decrease in virulence that's been reported in the medical literature to date. There was an Italian physician who made some kind of ridiculous comment about how there's really no more virulence in the virus in Italy, and that was shot down very quickly. And the virus maintains its virulence, but I haven't seen confirmation of that, at least in the literature that I'm following. So the vaccines, hopefully, you know, and I can say a lot about vaccines, but hopefully the vaccine trials that are going on right now will have afford protection against all of the circulating strains, which can be identified. The original strain from Wuhan, the strains from Seattle, the strains from New York, strains from Western Europe, they can all be identified because they all have characteristic mutations.
Debbie, I'm going to ask you two questions. The first is that if you could speak a little bit about herd immunity, what it is and how it works. And then the second, there's a number of questions coming in about how does one boost your immune system? And is there anything else that could help safeguard? I know in March, virologists were saying that zinc and having zinc lozenges twice a day or something would stop the virus from taking effect in one's throat, which seemed to be a major point of contact. But are there other things that help boost the immune system or safeguard the virus?
So I don't know of anything that would do that, including zinc. I don't think the data for zinc are compelling at all.
Okay.
My father-in-law used to was a big proponent of zinc. He's a CPA, you know. Anyway, there were no data. You know, zinc was pushed for all kinds of viral upper respiratory infections, but the data never supported the use of zinc, and I don't know of anybody that is pushing zinc. Herd immunity is, oh boy, I have a great slide that explains this. Herd immunity is when a pathogen, or like a virus, will spread through the entire population, and then the bulk of the population becomes immune to it, and all of the people who are immune around people who are still susceptible decreases the risk that the susceptibles will get that infection. So for example, a child who's immunosuppressed may not be able to get vaccinations for measles, mumps, and rubella, which are live viruses. But if all of the kids around that child are immune by virtue of the fact that they are vaccinated, they will buffer that child so that the child won't get infected. For an infection like measles, herd immunity is 95%. So you need to have 95% of the community immune, either by natural infection or vaccine, in order to protect the individuals who can't be vaccinated or who are not infected. For SARS-CoV-2, herd immunity is in the range of 60 to 70%. I've heard different estimates. Herd immunity is what Sweden, I think, was trying to accomplish by not really taking drastic measures to decrease transmission in their country. And it's turned out to be a very bad idea because their death rate is one of the highest in the world. And so herd immunity, by just letting the virus go in the community, comes at a very high cost in terms of death. So the Swedish health minister is now backpedaling his original recommendation that they should kind of let things go. They didn't 100% let things go, but they didn't really do what a lot of the rest of the world did, and now they're paying the price for it in a lot of deaths, huge death rates going on.
Mm-hmm. Okay, we have a question from Linda. Linda.
So this is a strange question, but what do you see as the timeline for ever getting back to elective surgeries that involve having to fly down, say, to LA because the family can take care of me with a hip replacement? And how safe any of that is, how okay it is to even consider elective surgeries at this point?
Most medical centers are now opening up for elective surgeries, certainly in the Bay Area. And, you know, elective surgeries, that's a main revenue generator from hospitals. So they're highly motivated to start doing elective surgeries. And just as an example, they call my husband once a week to come in and get his cataract done. And I'm like, no. But I have been starting to rethink it. And, you know, we're probably ebbing right now in the Bay Area. That's not true in LA, though, but I'm just talking about locally. And this might be a time, a pretty low-risk time to do an elective procedure because hospitals are taking lots of precautions to prevent infections in the hospital setting. If I were to give you advice about having an elective surgery done in LA, cases are rising there. It's probably not the right time to do it, but at some point when cases level off and start to decrease, I think it would be safe to drive down to LA and then have it done there. I think driving is safer than flying. A short flight is safer than a long flight. So you'll take some risk if you are going to fly. I think driving would be safer. Maybe not what you wanted to hear, but.
Yeah. Debbie, we've got a couple of questions that are related to food safety and then also the question about whether or not we should continue to disinfect our groceries after they've been delivered.
I don't disinfect my groceries. My sister, who is also a physician, but not an infectious disease physician, disinfects her groceries, and therefore my mother disinfects her groceries. Why doesn't she listen to me? I'm the infectious disease daughter. My daughter is an internist, but go figure. So I don't disinfect my groceries at all. I just put them away. I don't wash my produce. I mean, I just wash it as I would ordinarily do. I don't wash it in bleach or anything like that. When I get food delivered, like takeout, which we get delivered to our front porch, we bring it into the house, we put it into the sink, and we clean our hands. And then before we eat it, I reheat that food because I just want to reassure myself that the person who was making that food, maybe they were wearing a mask, maybe not. Were they talking, laughing, shouting? Could they have sprayed virus onto my food? And so I put it in the oven at 350 for like 10 minutes and I reheat the food. So that means I don't get sushi. I don't get stuff that I can't reheat. And then, every time I touch the bag to open the bag to take out the takeout, I clean my hands. I'm constantly cleaning my hands when I'm going through this process so that I don't contaminate the food or my face or whatever.
And they have been saying, the CDC, that the virus lives on cardboard for 24 hours and 72 hours on metal surfaces.
Yeah,
okay.
Correct. So that's why people will sometimes they'll put their mail away and then not open the mail for 24 hours, extrapolating from the cardboard data, because we don't have data for paper. I had been doing that. I'm going to stop doing it. I think it's really safe to open your mail, to recycle what you're going to recycle, read what you're going to read, and then clean your hands. And just don't touch your face while you're dealing with the mail. And I think it's not necessary to wait 24 hours on the mail, and I'm definitely going to stop doing that.
Well, we've got a lot of questions on just, how far to go with the infectiousness, but I realize it might be good to shift over to some questions around the vaccine. And, what your thinking is around, I know it's an impossible question to answer right now around the timeline, but could you give us an update?
Yeah, so there are currently over 130 vaccine candidates that are in some form of development where there's been enough investment to push things forward. And there are currently, I believe, 7 vaccines that are actually in human trials, either in phase 1 or phase 2. The whole timeline for vaccine development has been incredibly sped up compared to past vaccine development. And I've never, no one's ever seen a timeline like this. There is a lot of emphasis on getting a vaccine available for distribution by October of this year. The Oxford group is very interested in having vaccine for distribution. I believe they're partnering with AstraZeneca to have vaccine by October. And why October? October is the month before November. And I don't think that that is a good enough reason to target October. So I think that it is much more reasonable to think that sometime in mid-2021, there might be a vaccine that has shown efficacy in large numbers of people that doesn't show a safety signal once it goes into, phase 3, which is putting it into, tens of thousands of people and then letting them become exposed just naturally. I think before the middle of 2021 is really unrealistic, and even the middle of 2021 might be unrealistic as well. I listen to the UCSF Grand Rounds every Thursday, which is on COVID every Thursday. And last Thursday, one of the speakers was a former head of the Food and Drug Administration under the Obama administration. And he said something that was very shocking to me that I did not appreciate, and that is that the FDA commissioner reports directly to the Secretary of Health and Human Services, who's a cabinet level, and that individual reports directly to the president. And it means that the president could say, I want the FDA to grant emergency use authorization to this particular vaccine. And that doesn't have to depend on any data. The president can just order it and the FDA commissioner has to do it. And that's, I think, what happened with chloroquine and hydroxychloroquine. There was tremendous pressure from the White House for the FDA commissioner to grant emergency use authorization for those two drugs, which, by the way, it retracted this week.
Right.
And so it gives me some anxiety about, I'm going to really want to see some data before I take a vaccine, because I want to have some assurance that the proper safety signals have been looked for and not seen, and I want to actually see some data before I would take a vaccine. And I am a big proponent of vaccines, but this whole situation is politicized, and it makes me anxious that maybe something's going to come to the market too soon.
Understandably. One other part then, if we move from vaccines to the treatments that minimize some of the harrowing symptoms of COVID-19. Any thoughts about those things?
So remdesivir is an antiviral that is now considered standard of care. It is not a game changer by any means. And I think there's studies that are ongoing using that drug earlier in the course rather than in people who are really sick and in their storm of cytokine storm. There are other drugs that are being looked at. Some drugs that wouldn't immediately come to mind as antiviral drugs, like ivermectin, there have been some drugs identified like tricyclic antidepressants that may have some activity against this virus. There was just data presented by the Oxford group about using dexamethasone, which is a really commonly available steroid in patients who are in respiratory failure from COVID-19, and I think that's going to become that uptake of that drug in very sick patients is going to become the standard of care very quickly. What other drugs are being used now? There is a Japanese antiviral which comes in an oral form that's being looked at. I have not seen data from that yet. Convalescent plasma is being collected avidly from people who have recovered from COVID-19. There was just a study published from China showing no effect of convalescent plasma. And there are some concerns about it because it contains clotting factors, and deep venous thrombosis, pulmonary emboli are a very common complication of COVID-19 in people who are in their second, third week of illness. And so there's a concern that it might make the risk of clotting worse. So what else? I've presented on so many things. Those are just the things that come to mind right now from the talks that I've been giving.
Someone asked a question about, what about progesterone? I haven't heard about.
Oh, yes. So, we know, so that's a very good question. We know that men are hit with this virus harder than women. So the rate of more men require high flow oxygen, mechanical ventilation, ICU care, and more men die compared to women. And that's really been borne out in, the Chinese data and also here. It was initially thought that maybe it was related to smoking, since more men smoke in China, but that may not be, that may just be one reason. And so there are investigators who are looking at anti-androgenic compounds to see if that would make a difference in individuals who, and I'm not sure at stage of their illness. I haven't looked at those data. There's a clinicaltrials.gov. You can look up any study that's being done because those all have to be posted to that government website, and you can see what the inclusion criteria are and the exclusion criteria, et cetera, what their primary and secondary endpoints are. And I haven't looked at those, but I know that there are some investigators who are using, I believe, anti-androgenic compounds, maybe progesterone, to see if there's an effect in people with COVID-19 infection or disease.
And that was called clinicaltrials.gov?
Yeah.
There's a question about Vidavir, that's a Russian, an antiviral from Russia.
I don't know anything about it.
All right.
I don't know. I can say something I just saw in the chat about someone's asking about blood type.
Correct. Yeah.
And there is definitely, there was a genome-wide analysis that was done on very large numbers of people, and they identified signals. Some signals on chromosome 9, which corresponded to the ABO blood type locus, and they found that individuals with type A blood, which would be, I guess, AA or AO, and I was not happy to see this because I'm type A, have a 45% increased risk of severe COVID, meaning, and they define that as requiring oxygen or mechanical ventilation. And people who have type O blood have a 35% reduced risk of severe COVID. So type O blood seems to be protective, and type A blood confers an increased risk. And I don't know if that will be borne out in other studies, but it was an interesting and consistent finding in this study, which has not been peer reviewed and not published anywhere yet, but it will be.
Okay, we have a question from Larry. Larry Bathgate, are you with us?
Yes, I am. Well, this goes back to the masks. I don't know, why isn't there a lot of information on how to wear a mask? I see people wearing a mask and it's down below their nose, and why wear a mask at all? I mean, also, when I'm driving in my car with a mask, I don't want to be taking it off and putting it back on again when I'm going from one store to another, because sometimes I go to the nursery and then the food store, hardware store, that kind of thing, you know.
Oh, so you just keep it on?
Yeah.
People, it does need to cover your nose and your mouth, that's for sure. And it needs to fit well so that there's not leakage out of the sides, because if there is any, whatever filtering efficiency that mask has, if it's leaking out the sides, the filtering efficiency can be 60% of the filtering efficiency can be lost. So it's really doing nothing. So it should fit well, and yeah, it should fit well. So it's not leaking.
There's one other question about a mask, about can the medical masks be sprayed with alcohol?
I don't know. Yeah, I don't know.
Debbie, we're at 4:34. Are you okay and going on for, say, another 10, 11 minutes?
Yes, that would be okay.
Okay, great. Max, do you have any more questions?
No more hands up at this moment.
Okay, I have questions on my list here from things that people submitted. Somebody asked a very interesting question. I think this is super interesting. Will having shingles give any immunity to COVID-19? I think it's a really interesting question, because when you get an infection, it stimulates what's called your innate immune system, and your innate immune system gets turned on, and it doesn't really care what the pathogen is. It will, fight any pathogen that it sees. And so I don't know specifically about whether natural shingles would confer immunity, but I know that there is a lot of interest in polio vaccine and BCG, which are both live attenuated vaccines being given kind of to everyone to try to stimulate their innate immunity to reduce the burden of severity of COVID-19. And there was recently a letter in Science, I think, written by Robert Gallo and some really big names pushing this idea of using live attenuated vaccines that are already available and on the market and known to be safe to sort of give to the entire population to try to decrease the severity of disease by turning on the innate immune system. I think the problem is, especially when they're talking about oral polio, is that oral polio vaccine back mutates to wild type polio. And so where there are polio outbreaks in the world, like in Pakistan and in Nigeria, when they report those, and I get these reports every day in my email, they'll say how many cases that were diagnosed in the last week that were vaccine strain polio cases and how many strains were wild type strain polio. So when you're talking about giving oral polio vaccine, which is really what they're pushing because it's cheap and there's a lot of it and it's easy to make, you're probably talking about very unfortunate cases of back mutation to wild type strain, and then kids getting polio. And I think that would be absolutely awful, but it's such an interesting idea about finding ways to stimulate the innate immune system. Somebody asked this question, which is very important, I think. When you get a negative test for COVID, how long is that good for? And I think it's good for the day that you have it, that you have the test, because you could have been exposed 2 days ago and you don't have enough virus yet to be picked up in the test, and you're already infected and you're infecting, you don't have very much virus, or you could be exposed that day and incubating, or you could be exposed to the next day and be incubating. And so I think it's good for the day that you have the test. And when I heard this discussion, it was on the Daily podcast from yesterday, which was Don McNeil. He was talking about corporations who are thinking about how they are going to screen their workers, and people are talking about screening every day to know who's asymptomatically infected so that they can, exclude them from the workplace. But we can't do that right now because we don't have the testing capacity to do it. Eventually, we might have testing capacity to do it. And you would actually be testing people every day.
Mm-hmm. Did you hear about the, is it the Malinois shepherds that are a breed of dogs that are able to identify who has the virus? Some with close to, between 95 and 100% accuracy.
I'm not surprised because dogs are amazing, and they can, the Dutch are very into having dogs identify infections, and they have taught, they have beagles that are taught to identify Clostridium difficile infection in patients, and they take the dog into a patient room, and if the dog sniffs the C. difficile toxin, the dog sits, and then they know that's a case. And the dog won't sit if there's no C. difficile. I totally believe that, although I hadn't heard that.
Uh-huh.
It has been identified in cats, in dogs, in minks, in I think ducks or chickens. No, not ducks or chickens. Anyway, but dogs and cats for sure, and minks for sure. And minks have transmitted COVID to humans from mink farms. And why are there mink farms? Mink. There's mink farms, and they're in Holland, and they produce mink to make mink coats to be sold in China.
Yep. Max, do you have anybody else ready to ask a question? We've got a lot of questions, Debbie, about just, you know, going to the dentist.
Yeah.
A couple of questions about whether or not to get the shingles shot. And I want to return to another question, which I heard you answer at San Francisco State's discussion on Friday, which was the ways in which you're allowing some socializing with social distancing. And I think that would be fun for us to hear how you're doing that.
Yeah. I have a Friday afternoon coronavirus lunch club in my backyard. And these are my friends. We all retired at the same time. Our kids went to school together from kindergarten. We used to play mahjong together after we retired, and we do need to see each other. And there are like 8 of us. They come into my backyard through the alley. They don't come into my house. They don't use my bathroom. Everybody has their own camping chair. Everybody brings their own lunch, their own drink. And we just sit around and talk. We don't do very much during the week, so we don't have all that much to talk about. But I think that that is a safe way to socialize. While we're eating, we don't have masks on, but when we are not eating, we do have masks on, and we're all sitting 6 to 10 feet apart. And some of the people don't hear so well, so there's kind of like yelling a little bit so everybody can hear. But I think that that's pretty safe. Yeah, so I'm continuing to do that. As far as getting a shingles vaccine, you have to just decide when you think your risk tolerance allows you to go in to get routine medical care. I think it's really important to get the shingles vaccine because it really is a robust vaccine and it works. It will not stimulate your innate immune system though, because it's a subunit vaccine. It's not a live attenuated vaccine. And so whenever you make the decision for yourself that you're going to go in to get just a routine medical care, definitely get that vaccine. And I would try and do it on a Friday or when you know you're not going to have something important to do the next day, because it's a whopper, and about 10% or more of people who get it get, you know, a really robust reaction to it, like fever, chills, feeling terrible, and then you have to get it again in two to 6 months, and you can get those same symptoms again.
You know, I think that one of the things that for all of us who have been staying at home, quarantine, you know, we're very concerned about the resurgence in the fall. And you mentioned, you know, that one vaccine was trying to get out in October. Obviously, that's flu season in November. And so just tell us a little bit more what you're imagining the dimensions of the resurgence and how we need to be proactive.
So as people get out more and more and restrictions are lifted, there will be more cases, and that's a given. And so as long as we understand that there are going to be more cases, as long as we have a robust testing system and a tracking and tracing system where we can identify cases quickly, get their contacts traced, get their contacts in quarantine, we should be able to keep things under control. In places where it starts to get very cold in the fall, and especially in the winter where people are inside a lot, if restrictions are lifted and people are eating in restaurants and going into bars and just being in more congregate settings, then we have to worry about super spreader events. We have to worry about more cases and not being able to keep up with those cases as far as testing and tracing. And then subsequently overwhelming the capacity of hospitals, hospital beds and ICU beds and ventilators, et cetera. I think we have an advantage here in the fall that it's still going to be very warm and people will be outside more. So at least we have that. But, you know, in other places in the United States where it's going to start to get very cold and people are staying in but want to still go out, that's when we're going to be seeing more cases. And, you know, we will have a surge, although the surge may not happen here. The rock star epidemiologist that I follow at UCSF, George Rutherford, says we will have a surge here, but it may not coincide with the rest of the country.
Debbie, you know, a world of thanks to you. This has been really, really helpful. I know we haven't gotten to everybody's questions, but you had offered to me privately that you would be interested or willing to return again to an OLLI conversation.
Yeah.
And so with that in mind, is there, you know, what would be a good time?
I think in a couple of months, we will be in a very different place because we will be through phase 3. We will have a lot more reopenings. We will be seeing surges in many parts of the country. That's going to happen in the next month or so. We're going to see a lot more cases in places in the middle of the country that don't have a lot of cases right now. As people are getting out and getting around each other more. Schools are going to open in the fall to one extent or another. And so especially with teenagers, college students who are going to totally blow off the the social distancing and the mask. I think we're going to see more cases even here. So I think a couple months would be a good time to try and do this again.
Well, thank you. As I said, it's been very, very, I mean, we've covered a lot of ground. Let's, you and I take a look at the questions and see what else we should respond to.
Okay.
In the meantime, thank you for the offer to do that. I want to thank everybody who's been a part of this conversation. Your questions have been spot on, and Debbie, your answers we're in your debt. Thank you.
Thank you. And I have to say that a lot of these questions were as good as a very good third-year medical student questions. So kudos to you for asking these very thoughtful questions.
That's great. We'll take that. All right. Thanks again. Bye-bye, everybody.